Thank you to CCIG for the opportunity to talk about the study developing a decision aid to support parents when their child has relapsed or refractory neuroblastoma, also known as the REDMAP study. My name is Helen Pearson. I'm an advanced nurse practitioner for children and young people diagnosed with solid tumours at the Royal Marsden NHS Foundation Trust, and I'm a PhD student at the University of Southampton. This research study is done in collaboration with two academic supervisors, Professor Anne-Sophie Darlington, who is a professor in health psychology at the University of Southampton, and Professor Faith Gibson, who is Professor of Child Health and Cancer Care at the University of Surrey, and Chief Nurse for Research at Great Ormond Street Hospital. So in order to develop a decision aid which supports parents when making treatment decisions for their child, we first need to understand the decision-making research that has happened up until this time point. So we know that decision-making is a partnership approach between parents and healthcare professionals, and including the child where appropriate, and something that requires quality information and consideration of individual values and preferences and what is important to that person who is making that treatment decision. There have been decision-making research for single events within children's cancer. This has been, for example, whether to participate in a phase 1 clinical trial or to opt for symptom management alone and not cancer-directed therapy in poor prognosis cancers. Research has shown that decision aids can support complex decision when there is uncertain and variable outcomes, such as in the case of relapsed and refractory neuroblastoma. So what do we know about decision aids? We know from a systematic review looking at decision aids within adult cancer care that they have had a positive effect on decision making. They can reduce decisional conflict and decisional regret, and they can increase participation and confidence in making treatment decisions. They can also help facilitate discussions with healthcare professionals. Within children's cancer, there is one decision aid called Delta, developed by the team in Sydney, Australia, that is for parents and adolescents who are considering participation in a clinical trial. And generally within children's care, there are decision aids for single events, for example, medication choices in juvenile arthritis, and procedures and support for children who are requiring tonsillectomies. So what is a decision aid? It has 3 key components. It provides information on the treatment options that might be available and includes values and preferences which might be important to the person who is making the decision. This is usually displayed in some sort of a scale or preference of a rating of 1 to 5 or 1 to 10 that people are able to decide upon. And they can facilitate conversations with healthcare professionals. What they don't do is advise which treatment option someone should choose, and they don't replace conversations, discussions, and information provided by healthcare professionals. In my clinical experience of supporting and looking after children with relapsed or refractory neuroblastoma, is that parents have no previous experience of making treatment decisions because this is protocol driven. They want to be involved in making treatment decisions, but they can feel the emotional burden of making repeated treatment decisions depending on their child's response to treatment. And in some cases, parents can feel conflict and regret around decisions which they make. High-risk neuroblastoma, 40 to 50% of children relapse. And at relapse, there is no standard treatment protocol, but varying treatment options available. This means parents are presented with these treatment options, and they may make repeated treatment decisions depending on their child's response to treatment. In July this year, we decided to include parents of children with refractory disease. Approximately 15% of children are termed refractory if they don't meet the milestones required at the end of induction chemotherapy on the frontline protocol. There are, again, various treatment options available, including a protocol-driven refractory option called Veritas, which has just opened within the UK. And so we wanted to include parents that have a crossover in relapse and refractory. So these parents who are making repeated treatment decisions that are off protocol. This study is hugely supported by patient public involvement. The group consists of parents and carers who have experience of having a child with relapse or refractory disease. this group was developed from the outset of the study back in 2018, and they have been involved in, they've developed REDMAP, the acronym for the study, and the logo that accompanies that. They have co-designed the research study website. They have been involved in all parent-facing materials. So they've been involved in developing interview questions, the information sheet, and the consent form. And I've had a huge involvement in ensuring that this study provides the opportunity for parents to be involved, but to try to minimize that emotional burden of being involved in such a decision. So huge conversations around when parents should be approached and at what time would be the best time to approach parents after they've made a treatment decisions. And importantly, they wanted to show the sequential and repeated treatment decisions that these parents can make off protocol. And so they developed a flow diagram for parent treatment decision making in relapsed and refractory neuroblastoma. Initially, this was just for relapse parents, but has been updated this year to include parents of children with refractory disease. And as you can see here, in both situations for relapse and refractory, there are various treatment options available. Parents will have this discussion with their healthcare professionals, and then they'll have a decision point to decide which treatment option to choose for. Their child will then receive that treatment with or without symptom management, depending on the symptoms their child may be experiencing. And then they'll have scans to reassess the disease. And at that time point, they may make another treatment decision, depending on whether there has been a response to treatment, there has been stable disease, or whether the disease has progressed. And as you can see from this flow diagram, that this can be a repeated occurrences depending on the child's response to treatment. So the REDMAP study, it aims to develop a decision aid which supports parents in treatment decision-making when their child has relapsed or refractory neuroblastoma. And there are several steps to do that, which include a literature review of what is already known about values and preferences in treatment decision-making, and interviews with parents who are making these treatment decisions at this current time. Once the decision aid has been developed, it will be user tested with parents and healthcare professionals to look at its usability and acceptability ready for use in clinical practice. So the study has been designed in 2 phases. So in phase 1 is the literature review, which will be paired with theories around how people make decisions in everyday life. This will be combined with the data from the parent interviews, and then the combination of the data will be used for phase 2 in the development of the decision aid. So where we are with the study currently is the literature review is looking at 2 questions. What are parent values and preferences when the child is receiving cancer-directed therapy for poor prognosis cancer? And how do these values and preferences inform treatment decision-making? This is being done as a scoping review, as a type of literature review. The protocol has been published. It is open access, which means anyone is able to access it. And the scoping review report is currently being written. And this week, I've met with one of the parents from the patient public involvement group who is involved in analysing and picking out the themes that has come from the literature review. If we'd been a couple of weeks later for this presentation, I'd be able to share some of the findings with you, but we're very much in the preliminary stage of that, so we're just not quite there yet. And in terms of the parent interviews, questions around how parents make treatment decisions, and does their decision-making change over time with the more treatment decisions that parents make? And the inclusion criteria for these is parents of children who are receiving treatment currently for relapse or refractory disease, but this excludes the Veritas protocol as that is protocol driven. They have recently made a treatment decision. Their child is under the age of 12, and that is because a lot of decision-making research involves children who are 12 and above. Parents can be re-interviewed if they make more than one treatment decision whilst phase 1 is open, and both parents can participate. And we're really keen to hear the voice of fathers who from the previous research has shown that the father voice is lacking. And so in terms of recruitment, there was 12 treatment centres open within the United Kingdom. During COVID last year, we opted to amend the study so that parents could self-refer, to increase participation, and to also include parents whose treatment centre might not be participating in the study. So far today, I've undertaken 9 interviews with 11 participants, so 8 mothers and 3 fathers. And in total, they have made 12 treatment decisions, and that can be between 1 treatment decision up until 6 treatment decisions. The initial analysis for this interview data is going to start next month, and there are ongoing interviews set up for the next few weeks. So in terms of phase 2 and the development of the decision aid, as mentioned, obviously the data from phase 1 will be used for this. And there will be a steering group that consists of parents and healthcare professionals throughout the development. And the development of the decision aid will be underpinned by the International Patient Decision Aid Standards that provide a robust and systematic way of developing decision aids. Once the decision aid has been developed or is in draft form, it will be user tested with parents and healthcare professionals, as said, to ensure that it is usable and accessible to parents, ready for use in clinical practice. In terms of the timelines, obviously COVID has delayed things, and so phase 1 interviews has been extended until early summer next year. This will be very much dependent on the number of participants at that time and the data analysis up until that time point. It may be that might need to be revised, but if not, we then plan to go on to the development of the decision aid, which is estimated to be ready in early 2024. I'm more than happy to take questions during the Q&A section at the end of this, and thank you for listening.